Right, good evening and welcome everybody to tonight's webinar from the Institute of Sport, Exercise and Health on calf tears in sport. We're very lucky tonight to have two extremely talented academic clinicians talking to us. This webinar has actually come about when I sparked the interest of the recent publication, the ultrasound classification of medial gastrocnemius injuries. And speaking to Lorenzo, who's a colleague of mine at the Institute of Sport, I said, look, why don't we do a journal club? And he came back and said, why don't we do a webinar and get the main speaker on? So we're very lucky to have Carles here tonight. So tonight's format will be quite simple. Next slide, please, Kelly. Here we go. So the introductions from me, then will be a case example with some thought process from Lorenzo, and then into the main event. So a couple of things for this evening. We're very fortunate that some high quality questions have come in the preceding 2 weeks to this event. So this talk has been bespoke for you, the audience, and we're very thankful for that. But if there are questions that you do want answering, please ask them in the chat function below, and Lorenzo will be screening those throughout. And any questions that haven't been addressed by Carlos's talk, hopefully Lorenzo can then ask Carlos those. So without further ado, introduction to Lorenzo. Lorenzo is an SEM consultant here with us at the Institute of Sport, Exercise and Health and with the military. He's a previous doctor with Wasps Rugby, Fulham Football Club, unfortunately the Melbourne Storm and Tennis Australia. And he leads our tendinopathy clinic at the Institute, and his interests are obviously muscle injuries and tendon. And Carles, well, his background is quite formidable. PhD in medicine and surgery, University of Barcelona. He's a sports medicine specialist at the University of Barcelona and published extensively on the diagnosis, the treatment, the return to play processes of muscle and tendon injuries, and who hasn't he consulted for in the world of sport. So there we are. And Lorenzo, over to you, please.
Thank you, everyone, for joining, and I appreciate the invite. I'm just going to do a really quick introduction on calf tears. I'm a sports and exercise medicine consultant, and I see a lot of muscle injuries and also a lot of calf tears, and very interested in the work that the Spanish and the Catalan group have done, particularly in the field of muscle tears and also particularly in calf tears. So hopefully you'll find this quite inspiring and learn a lot from it. What is the problem with calf tears? Well, if you look at muscle injuries generally, they make up 30% of all injuries in elite sport. And the important thing here is that the highest risk factor for a tear is a previous tear. So 60% of re-injuries occur a few weeks after a return to play. So it's absolutely important that you manage these injuries correctly. If you look at this study, this is another Spanish study. This is an epidemiological study on basketball players, elite basketball players by the group in Barcelona. Muscle tears were actually more common than ankle sprains. And out of the group of muscle tears, calf muscle tears was the most common muscle injury. And calf muscle tears made up it was second in time loss of muscle injuries. So a really, really common injury, particularly in elite sport. We also see it in the weekend warrior. And this was from that paper, and the graph in blue is the ankle sprains, and you can see the graph in green is the muscle strains. So the muscle strains definitely have more time lost and more medical attention compared to ankle sprains. So when I was working at Wasps Rugby, certainly when I started in 2011, we had 10 calf injuries in 6 months. And in fact, we had a calf injury every 2 to 3 weeks. And out of that group, there were 9 SOLEUS injuries and 1 medial gastrocnemius injury. And what I found with these injuries was that despite the severity of the injury on clinical presentation being the same, there were significant differences in return to play. So that ranged from between 1 week and 3 months. And why this was so, I wasn't 100% sure until I read the studies by the group in in Barcelona. They did these studies on SOLEUS muscle tears and also in medial headed gastrocnemius tears. So hopefully we can learn a lot about why some of these players return to play in a couple of weeks versus, in some instances, up to 3 months. But what we also have to remember is that not all calf muscle pain is a muscle tear. And certainly these are all the differentials that we need to think about when we're talking about calf pain. So proximal Achilles tendon tear, DVT, popliteal artery aneurysm, stress fractures, referred pain, chronic compartment syndrome, ruptured Baker's disc, plantaris tendon rupture. And this is not all a comprehensive list. But what I really want to focus on is these top 3, proximal Achilles tendon tear, DVT, popliteal artery aneurysm, because potentially these can be career-ending in some instances with a Achilles tendon tear, or potentially life-threatening injuries such as a DVT. And these are the sort of injuries that keep me up at night. So hopefully during this webinar, we can also talk about how we differentiate calf muscle tears from these other possible differentials in calf muscle pain. So I'm going to hand off to Carlos to go through his talk discussing the various classifications of calf muscle injuries, and then we'll come back and have a list of questions to ask him specifically about practical management.
And first of all, I would like to thank you for inviting me to speak about calf tears in sport. First of all, you see the screen? You can see the screen perfect, and you can hear me correctly?
Yes, both perfect.
Perfect. Then we're gonna start. Let's talk a little bit about muscle tears in a sport. So, is it just muscle, aponeurosis, tendon? Does it matter? Let's try to share a little bit of light on that. First of all, as always in my talks, I think it is very, very important to understand the anatomy of every region we want to know about it. And the first thing that we need to understand is that the calf muscles, we need to understand it as a whole structure. The gastrocnemius, the soleus, the Achilles tendon, the plantaris, even the deep flexors, we need to understand them as a whole structure. So we have a proximal gastrocnemius, or medial gastrocnemius, lateral gastrocnemius, obviously, with the aponeurosis, the soleus just below. Here we can see it in this paper from Blitz et al. And obviously, the soleus muscle with the medial lateral aponeurosis and the central tendon. We will talk about soleus muscle later because this soleus muscle is quite beautiful with its medial aponeurosis, lateral aponeurosis, central aponeurosis, but not all the soleus muscles are as beautiful as this one. So, but this is not a question we're going to talk about when we speak about the soleus muscle a little bit later. We need to understand that this complex is like a book. When we open a book and we can see plantaris tendon here, and this is the soleus aponeurosis, so the soleus is just behind this structure, and we open the medial gastrocnemius and the lateral gastrocnemius, so we can see here a big hole like this one between the gastrocnemius and the soleus, and this is the intermuscular space. Here we can see an image, an endoscopic image, when we remove the blood cold from an intermuscular fibrotic hematoma, that you can see the huge space that we have between the soleus and the gastrocnemius. And this, if there is no problem, is a virtual space. So here is where the hematoma will go if we had a rupture. When we scan with ultrasound a calf, it's not just about thinking of where is the calf tear I suspect. We need to scan all the calf from the knee to the calcaneus bone, the whole structure, because this, as Lorenzo said, it's not just to see if there is a calf injury. We need to understand where is it, which structure it affects, and if there is any other diagnosis. Because as we can see here in the other, in another anatomical piece, we find here the medial gastrocnemius, here the aponeurosis, and here the soleus muscle, and it's all along to the Achilles tendon and to the calcaneal bone. It's like this structure here we can see. The gastrocnemius, aponeurosis, the soleus aponeurosis, and the plantaris tendon. Look that the soleus muscle is still running, but the gastrocnemius muscle ends here. So we can speak here to the free gastrocnemius aponeurosis. And if we focus exactly on the area where the most injuries is going to be, we can see that it's this area around here, the distal myotendinous junction of the medial gastrocnemius and the virtual space that we saw before. Here is the soleus muscle. And as we can see here, the attachment of the fibers of the medial gastrocnemius to the aponeurosis is very, very strong and very hard. So this aponeurosis can support a tear without torn this aponeurosis. So this is another important question. And another big important question is that the muscle ends here. So all of these, until we call the Achilles tendon, it's the free gastrocnemius aponeurosis. And look that there is a hard connective tissue structure, same as the Achilles tendon. If we look at it in ultrasound, in a panoramic ultrasound longitudinal view, we can see all these structures. We can see the medial gastrocnemius here, all the soleus muscle, the flexuralis longus, the carpal tunnel, obviously the Achilles tendon, and this, as we can see, and it is described in the literature, we can find independent gastrocnemius aponeurosis here, an independent soleus aponeurosis here, and abruptly they fuse and they form the Achilles tendon, the proximal Achilles tendon and the distal Achilles tendon. And this is important because not only because we can have a tendinopathy in the whole Achilles tendon like we can see here, but also we can have some different kinds of ruptures in different of these spaces. And this is very important. Look here, for example, when I am putting the probe in the longitudinal axis is very, very far. Look that this is the normal scan that we see when we look at the medial gastrocnemius, and we see here the normal injuries. Here we can see it completely normal scan. But if we move very distal, we can see that there is a posterior soleus aponeurosis there. We can see it here in a transversal video, that here we can see the aponeurosis is completely normal and it ends the gastrocnemius, and we can see here this subacute posterior aponeurosis of the soleus injury. So that's why we need to scan all the structure, and sometimes we need to go very, very distal to find what we are looking for. So when we speak, we normally use the term tennis leg. And what is a tennis leg exactly? A tennis leg is not an injury of the medial head of the gastrocnemius. Tennis leg is a syndrome. It's an acute pain in the posteromedial region of the calf plus functional limitation. And this was described as this. Normally, it's true, it's due to a medial gastrocnemius rupture, it's the most frequent, but it can also be a plantaris rupture or a soleus rupture. And a very important thing to take into account is that the intermuscular hematoma is just one of the signs that we can see in a tennis leg. Not always. It's not mandatory to find an intermuscular hematoma in the tennis leg syndrome. So this was described as for Powell in 1883 in the Lancet. So we need to understand that the tennis leg is not an injury of the medial gastrocnemius. It's just a syndrome that means an acute pain in the posteromedial region of the calf muscles. Let's move on the medial head of the gastrocnemius injuries. We take this schema, as you can see, as the main structure to progress in this talk. And if we look at this schema, we normally see this schema is very similar to this scan, ultrasound scan, longitudinal. Here we have the gastrocnemius, the soleus, everybody knows. But if we make a dorsal flexion and a plantar flexion of the ankle, we can find that there is a synchronous movement between the medial gastrocnemius and the soleus muscle. This is very important. We will see later why is this really important. But this is the normal aspect when we make this dorsal flexion and plantar flexion of the ankle. So let's present the characters of the film. We can see the soleus muscle here. We can find the gastrocnemius medial aponeurosis because it's just below the muscle. Here we can see the free aponeurosis of the gastrocnemius, which is without muscle above. And here we continue seeing the soleus posterior aponeurosis. And here we can find the Achilles tendon. We can see in this video how gastrocnemius muscle here looks like. Look at this guy, and look that he is looking back as if someone has hit him. This is absolutely a medial gastrocnemius tear, and he has to stop immediately. So this makes us a suspicion of a medial gastrocnemius tear. And what can ultrasound share us in calf muscle injuries? This is what we're talking about, the article about the ultrasound classification of the medial gastrocnemius. And we've been working on that article for several years, and we've been applying this classification for several years, not just in the 100 patients that we have in the article. We applied it for hundreds and hundreds of patients. And what we found is that we can really divide the medial gastrocnemius injuries into 4 types. And the first one is that we have, look at the normal schema, we can have a myoaponeurotic injury without aponeurotic defect. That's we call type 1. But I really prefer the anatomical description of every injury rather than a number or an alphanumeric code. So let's look what happens. This is the medial gastrocnemius, and what happens is this. There is a rupture in the muscle fibers attached to the aponeurosis, but the aponeurosis resists and it is not torn. Just like this. It's very, very mild. And what we can see is medial gastrocnemius and soleus aponeurosis completely intact. We can follow them here. Fibroadipose septums retracted. We can see this undulation, this waving of this fibroadipose septum. The muscle fibers also retracted. There is very, very mild hematic suffusion. There is no intermuscular hematoma, and there is a synchronous movement completely preserved. So that is very mild injury, and that is what we call type 1. If we move to type 2, which is probably the most controversial one, here we can have a big aspect, a big types of injury in there, and we can say that there is a myoaponeurotic injury with an aponeurotic defect. So it's the same, but the aponeurosis is torn. And if we call it type 2. This is really important to know and to understand that the aponeurosis in the transversal plane, it can be measured completely, and it's very easy. So here we can see, for example, what will be a type A, what would be a type 2A here in the medial gastrocnemius. We can see that the aponeurosis is torn and there is a mild hematoma here. But, for example, this is a type 2B, a big hematoma inside. But what we need to understand, is this. look at this transversal plane because this explains the difference between type 2A and type 2B. Here we have the medial gastrocnemius. Here we can see the aponeurosis, and here we can measure exactly the defect of the aponeurosis. We measure it in the most wide defect area. So if there was less than 50% of the complete aponeurosis, we call it type 2A, and if it's more than 50%, we call it type 2B. So, for example, this is the type 2B, which is the whole aponeurosis rupture. It's a subacute injury. You can see scar walls in the hematoma, but this is a complete rupture of the hematoma in the transversal plane. We can see here in the video, look, that normally we scan the muscle, the calf muscles in longitudinal because we really know where the injury is, but the transversal plane gives us a lot of information. And we can see, for example, here. Look, that we can see where exactly the defect is absolutely here. So this would be a type 2A again. So here, look that the rest of the aponeurosis is completely normal, and here we can see the defect. In this other video, we can see that the aponeurosis, for example, is completely formed, and there is an hematoma inside there. And if we make the dorsal flexion and the plantar flexion, we can see, for example, in this one, it was a type 2A, that the synchronous movement is preserved. You can see that the soleus and the muscle and the gastrocnemius moves in a synchronic movement. But look at this one. This is the big hematoma inside. We have here the medial gastrocnemius. We have here the soleus muscle. And look, when we make the plantar flexion and the dorsal flexion, it only moves the soleus muscle. The gastrocnemius is up there, completely isolated. Put it again. So what we can see in a type 2 injury is the fibroadipose septum aspect completely retract, the muscle fiber aspect completely retract. There is an hematic suffusion between the septum and the aponeurosis. There is normally more or less intermuscular hematoma, and the synchronous movement, it depends on how affected is the gastrocnemius aponeurosis. As much aponeurotic defect, the most synchronic movement affection. So look, for example, forget the vessel here, forget the vein. Look here in this medial gastrocnemius here that we can measure completely and we can see completely the aponeurosis of the gastrocnemius. So we can measure it and we can say if the affection is less than 50% or more than 50%. Look here, for example, again, we can see that here is intact and here we can see the defect. And here the aponeurosis is still intact. So these are just examples to make you know and to make you see that it's very, very easy to see and to measure this white of the aponeurosis defect. We can see here that defect here. The rest of the aponeurosis is completely normal, and the defect is here in that case. And in this other case, the same. You can see here the normal aponeurosis and the defect is also here. For example, in this case, look that this is a hematoma in fibrotic phase here, but the affection is huge in that case. So this is more, we can see that this is more of 50%. So you understand perfectly that it's quite easy to assess that if the aponeurosis is torn more or less than 50%. Here we can see, for example, in the video, it's the last example of type 2, that we can see a big hematoma due to the big affection of the gastrocnemius aponeurosis. Let's move to type 3. Type 3 was a very interesting case because when we scan, as Lorenzo said, he didn't understand why some calf tears make just 2 weeks, a couple of weeks for a return to play, or a complete return to play, or some other have 3 months of return to play. And the same happened to us. We make a scan and we saw sometimes that there were some injuries that were very mild findings in ultrasound, even in MRI, but those injuries were for a long return to play time, and they had a lot of re-injuries there. And this is what we found. This is the type 3 injury. There is an isolated affection of the free aponeurosis of the medial gastrocnemius. And this is important to understand, and this is why I put the anatomical slides at the beginning of the talk, because as you saw, this is connective tissue, the same as the Achilles tendon. So we are talking about if we can consider it a tendon injury. And as you know, tendon injuries last a lot longer than muscle injuries in the return to play time, because the tendon metabolism is much slower than the muscle metabolism. So this can be considered as a tendon injury. And what we will see later, is that there is a very, very mild defect in the most distal point of the myotendinous junction of the medial gastrocnemius. Then we see as it is correct, but after that, it opens the free gastrocnemius aponeurosis. You will see some better examples here. A very mild affection of the distal myotendinous junction, and then is moving to distal to the free gastrocnemius aponeurosis. This is just an affection. This is the medial gastrocnemius aponeurosis, completely ruptured. And we can see in this video that we can see a thickened aponeurosis. It opens a little bit here, but look, the evolution to very, very distal, affecting the whole free gastrocnemius aponeurosis almost until the Achilles tendon. If we look at it in a transversal plane, the same. It seems that it's over, but it continues, the injury in the free gastrocnemius aponeurosis. And this is the typical thing. We can see a very mild, as I said, distal myotendinous junction affection here, and then the evolution towards distal into the free gastrocnemius aponeurosis. But we need to consider that, look at this, the ultrasound aspect of this injury is very, very mild. We just see this, not intermuscular hematoma. Normally, the synchronous movement is completely preserved. The muscle fiber aspect is normally is quite normal. The fibroadipose septums are quite normal. So the only thing we see is an affection of the free gastrocnemius aponeurosis. And sometimes this could be thought that it is a very, very mild injury, but we need to take into account this is a tendon injury, so the prognosis is worse. And finally, the type 4 injury, which is a mix between type 2B and type 3. So that means rupture of the gastrocnemius aponeurosis and progressing to the free gastrocnemius aponeurosis with intermuscular hematoma. So this is a big intermuscular hematoma and an affection of the free gastrocnemius aponeurosis. So we can see something like this. And obviously, this has worse prognosis because there is a tendon injury and an aponeurotic injury in the medial gastrocnemius with normally a big hematoma also. We can see here. And look that it seems that it ends here, but there is a progression towards distal. And the same here. We can move and look that there is some kind of tissue that pushes the medial gastrocnemius, but there is not a synchronous movement between the gastrocnemius and the soleus, so it is normally affected. So we can see in that injury a big intermuscular hematoma, normally affected synchronous movement, a free gastrocnemius aponeurosis injury, and an aponeurotic defect of the medial gastrocnemius. So this one is the one that has worse prognosis. And this is the image in this composition of the longitudinal scan, the hematoma, and the progression towards the Aponeurosis. So if we make a summary of all of this, we can have type 1 with a myoaponeurotic injury without aponeurotic defect, a myoaponeurotic injury with aponeurotic defect, that could be type 2A like this one, or type 2B like this one, a type 3 or medial gastrocnemius free aponeurosis injury, that one here, and finally a mixed injury that is a type 4 and is a type 3 plus 2B. So this is important if we have a table to make a summary. This is what all the things we have to look at when we scan in ultrasound calf muscle injuries. And until now, we gave a lot of importance to the intermuscular hematoma, but we need to understand that the most important thing is the medial gastrocnemius aponeurosis injury, the medial gastrocnemius free aponeurosis injury, and the synchronous movement affection or not, because it will affect the function. So the intermuscular hematoma is not an important thing, it's just a consequence. So if there is a big aponeurotic injury, we will find a big intermuscular hematoma, but it's just a consequence. It cannot be the main reason of the prognosis of the calf muscle injuries. So it's just a consequence of that. And if we make a comparison between professional football players and professional athletes, and workers, we can see with a significant P that if we avoid the workers and we speak only about the athletes, it's almost linear. So type 1, the less return to play time, type 4, the bigger return to play time. Also, this in workers, there is also a significant difference between types, but it's important to understand that we're focusing in the athletes, and in the athletes, the progression is almost linear. So this is very, very important with a very significant P. But is this enough? It's all of that? No. As I said, we can find some combination of things. We can find here, for example, a fibrotic scar from a 1 year ago rupture, more or less, a small rupture in the fibrotic scar. There is an extension to the free gastrocnemius aponeurosis, and finally, there is a partial rupture of the Achilles tendon, and this is all in the same mechanism. So it is important to scan all the injury, because we need to remember that this anatomically is the whole structure as a whole unit. We need to understand that. And this is another case. So this is not infrequent to find that we can find a rupture in the myotendinous junction of the medial gastrocnemius. Look, this evolution to the free gastrocnemius aponeurosis with this loss of tension here, and finally a rupture in the Achilles tendon, just with the same mechanism. It's this one. We all know that the mechanism is this hyper extension and forward in acceleration. So the only thing that we still don't know if it starts, this mechanism, if the rupture starts here and moves distally, or if it starts here and moves proximally. But we can find this injury, and it is not uncommon. So very, very important to scan the whole complex. And we can find something like also this thing here, which is a completely disaster about the medial gastrocnemius injury, aponeurosis, the complete SOLEUS tear, and also a complete tear of the Achilles tendon. That's what it could be called the fat injury, as Lorenzo said this morning in Twitter. Maybe it could be like this. So, is there always a rupture of the fibers in the medial head of the gastrocnemius in the tennis leg? In most cases, yes, but not all of them. It is not essential also that there is this type of rupture to talk about tennis leg syndrome. We talked about this. Neither does it require the presence of intermuscular hematoma. This is important to know. And to take home just in the medial gastrocnemius injuries, for me, ultrasound is the best choice for the diagnosis affecting the medial head of the gastrocnemius, to monitor the evolution and to decide the return to playtime. Important, the integrity of the intermuscular aponeurosis. If there is a rupture and the aponeurosis is not affected, just functional treatment. If there is a rupture and the aponeurosis is affected, due to the possible fiber of the scar, we need to make a functional treatment and ultrasound-guided drainage if it's needed to prevent or reduce the scar tissue and the fibrosis in order to protect the synchronic movement of the soleus and the gastrocnemius. And finally, if there is a free aponeurosis rupture, this is a worse prognosis because we can consider as a tendon tissue injury. And finally, type 2B and 4 are the most prone to affect this synchronous movement between the gastrocnemius and the soleus due to the bigger affection of the aponeurosis. So that are the ones that need normally immobilization. This is the unique case when I use immobilization in medial gastrocnemius injuries. So if there is some questions, if to drain or not to drain, I will let you think about this without saying anything. We're talking during the whole speech about the importance of the synchronous movement between the gastrocnemius and the soleus. So look, for example, to this coagulated hematoma, intermuscular hematoma between the medial gastrocnemius and the soleus, and this is going to develop a fibrotic scar tissue. If this is in the future, in the recent future, if this is going to be a fibrotic and hard scar tissue, just think in how it will affect the synchronous movement between medial gastrocnemius and soleus, or even that one that is making the scar tissue in the peripheral and it's still liquid or hematoma inside. So look how this big of scar would affect this movement. So, in my opinion, if I had to decide to drain or not to drain, I decide always to drain every intermuscular hematoma I see between the medial gastrocnemius and the soleus in order to make or to reduce as much as possible the thickness of the fibrotic scar tissue that will be that will develop this type of injury. And another thing that we need to take into account, and we are still looking to this video because this is the key point of everything, I think, to cast or not to cast. And this is very important again because I never make an immobilization of the medial head gastrocnemius injuries, never, except just one case. When it's completely, there is a completely loose of connection between soleus and gastrocnemius. In that case, I put a cast or I put a walker in order to, I drain out the hematoma and I put a cast in order to avoid the flexor, the plantar flexion and the dorsal flexion, and to try to recover this synchronic movement. And normally it does. So the evolution is very, very good in that cases with maybe just 1 or 2 weeks of immobilization, but just in this concrete case. The other ones, for me, we need to mobilize them very, very far at 48 hours, 72 hours. We need to start with physiotherapy treatment and all this stuff. So we end with the simple part of the speech, and we enter to the motor part of the calf, which is the soleus muscle. What do we know until now about the soleus muscle? We know that soleus muscle is a powerful muscle with highly variable anatomy and a huge connective structure inside. So it means that it has high risk of injuries. Please advise me of how I'm going about time because I'm not controlling because I have this screen here. So make me a signal if I'm
yeah. So we've got about another 15 minutes, Carlos, and then into the Q&As, and there's some good questions coming in that Lorenzo will ask you.
Perfect. So we also know that soleus is not just a postural muscle, as it was said a long time ago. It is a most important muscle in jogging, for example, important that we thought. So I think that we have neglected the soleus muscle for a lot of years. Soleus injuries are really misdiagnosed. Normally, they don't have an acute sharp pain. We will see it later. Previous soleus injuries predisposed to new injuries due to this huge connective structure it has. And we always talk about the individualization treatment of soleus muscle injuries, but we need to be especially careful with that in soleus muscles. And we can treat soleus injuries the same into different athletes, even into different sports. So this is very important, but that suggests me a question, which is the real role of the imaging test in the diagnosis of soleus injuries, especially the ultrasound. Is there a place for the ultrasound in the assessment of soleus injuries? Let's try to find it. We published these 3 papers, 2013, 2014, 2015. The first one, it was a description of the anatomical and injury distribution. The second one is the sensitivity of the ultrasound in comparison with the MRI. And we found that it was just 27%. And the last one was the return to play after soleus muscle injuries, depending on the injury site. So what we have learned about these studies of the soleus injuries is that we have 2 main problems. There is one big problem in the initial diagnosis because imaging is quite confusing. The patient felt it has specific symptoms there. So we have a problem in the initial diagnosis because we have this 27% and we have a high re-injury risk. And this is also because the initial diagnosis is not common. It's not correctly done, so it predisposes to a high re-injury risk. So what happens here? Look at these videos, courtesy of Dr. Safari Pal and Edward Richmond at Crystal Palace Medical Staff. Look what happens here. Look at this guy. I will explain you because the video is 1.5 minutes, more or less. So look at this guy. This guy is not running correct. He's trying to stretch. This is 1 minute later in the time. This guy is stretching, is jumping a little bit, is complaining. I think he doesn't know what's happening to him. He's stretching a little bit more here. He's trying to run. He's testing himself. Remember the Gastrocnemius injury, the guy in the field looked before as if someone hit him. So this is very, very difficult, very different, sorry. So this is 2 minutes later, and he's still in the field, but he's still, it doesn't work correct. He's stretching again, and finally we need to make a substitution, and it was a soleus injury. So when we made the anatomical study, we found a beautiful soleus. So we can describe perfectly that there was a central tendon, medial aponeurosis and a lateral aponeurosis, and the correlation with the anatomy was very, very clear and very, very perfect. So if we find this soleus, it's quite beautiful, and we can understand it perfectly how it goes. But what happens with soleus that normally it's not like this? What is very important to understand is that we need to avoid the re-injury risk. It cannot happen that due to a soleus injury we miss 33 matches in 2 years. This is a very, very huge amount of game and a very, very huge loss of money for every club. So we need to assess what's happening there. And we tried with this also with this study with injury distribution and the return to play time. And we find that in this distribution, we found that the central tendon injuries, as we can see here, a big central tendon injury, this is very nice, and this is very well seen with ultrasound. Normally they are not. They are the ones with the longest return to play time. And this is quite normal, and this is quite clear according to our knowledge nowadays. But we also found that the lateral aponeurosis was the ones with the better prognosis. And this is quite strange. if we know nowadays the knowledge that as much connective tissue affection, the worse prognosis, this is quite strange. So I don't really trust that the lateral aponeurosis has the better return to play time. What was it? I think that the key of all, I think this is theory of Prakash et al. That says that much more simple and much more clear. If there is an aponeurotic defect, the return to play is much worse, from 14 days to up to 70 days, just if there is any affection of the medial, lateral, or central tendon affection. Indifferent if there is not a rupture of this connective tissue inside the soleus muscle. So this is what is the much more important thing to take into account in soleus muscle. So why every epidemiological series and study and return to play time between series is very variable and without a predictable pattern? In my opinion, and asking with a lot of soleus geeks, as Santanil, Lorenzo, and a lot of guys, it's because there is an extremely high anatomical variability. And it makes it very, very difficult to categorize the injuries inside the soleus muscle. So we can find an accessory soleus or a distal insertion of the soleus. For example, this one. This is my soleus. Look where it ends, touching the calcaneus. So this is a very, very distal insertion of the soleus. We can find here an accessory soleus. It's a complete rupture, an isolated rupture of an accessory soleus, only seen with MRI. But the key point and the most important thing to take into account is the different width and length of the medial and lateral aponeurosis and the different shapes of the central tendon. So if you see MRI, because this is the only way to understand it is with MRI, if you see axial scans in MRI, you will find that the distribution of the lateral medial aponeurosis and the central tendon is not uniform at all. So we can find, for example, a lateralized and very small central tendon with a very long medial aponeurosis. We can find a medialized central tendon. This is the tibia bone, so it's very medial, this central tendon, with a long lateral aponeurosis here, and a very short medial aponeurosis here. And we can find, for example, a very hypoplastic and lateralized, this is the fibula, so very, very lateralized central tendon with lateral aponeurosis, that we can find it here, but without medial aponeurosis. So there is a huge, and we can be here putting axial scans of the soleus muscle until tomorrow, and we will see thousands of different combinations of medial, lateral, and central tendon aponeurosis. So it's completely a madness. So that the important thing is that conditions completely the different directions and pennation angles of the muscle fibers inside the soleus. I think that in my humble opinion, this is the reason why it's very difficult to assess correctly and to categorize correctly the injuries in the soleus muscle. Oh, sorry. Okay, perfect. So some helpful tips to plan the return to play process. Do not try to convert the soleus into a gastrocnemius. So it's not trying to train the soleus muscle to be a gastro. The soleus muscle is the soleus muscle, and we need to understand it. So we need to leave it alone, and it will repair quite good. We need to be careful with this trending treatment, which is sand circuits in the return to play of the soleus, because the sand circuit has a high core foot and flexor muscle demand, and this has a lot to do with the soleus tension. So the sand circuits in the soleus muscle for me are absolutely forbidden. we need to understand that there are neuromuscular and biomechanical adaptations and alterations that needs to be assessed also in this return to play process. Also, we need to load progressively, but we need to take into account that when the soleus works the most is when jogging. So let's start running a little bit, but not very fast. Maybe it's not the best option for the early stages of the soleus injury. And finally, we need to respect the biological repair process. We need to understand that in less than 3 weeks, a muscle injury cannot be completely repaired. And I know that that sometimes, most of the times, we put players into the field again in less than 3 weeks, but we play. Understand me when I say play, but we play with the risk benefit of putting a player into the field to play normal against the risk of a re-injury. But we know that in less than 3 weeks, this injury is not completely repaired, as we can see in these histological slides of a skeletal muscle. So again, to take home this time in soleus muscle injuries, soleus muscle is an extremely variable muscle. Think always about the anatomical variability and its implication when planning to return to play in the soleus. It is very important to know exactly which structure is affected and how much. In this case, the MRI for me it's much more superior than ultrasound in the assessing soleus muscle injuries. But I have to say that as much we know the soleus anatomy and its behavior, we can find a little bit more soleus muscle injuries with ultrasound, but it's still quite far from the MRI imaging test. There is a high re-injury rate due to an underestimated injury in terms of return to play time. So we put players to play faster than we should do. Also, take into account the role of deep flexor tendon, because calf muscles and calf compartment is a very stiff compartment due to all the aponeurosis and fascias that are there. So there is a big role of the deep flexor tendon, and injuries affecting the central tendon is the ones that have the worst prognosis, but almost the same as the medial and lateral aponeurosis. Finally, 3 slides to talk about that we can also find an isolated plantaris injuries. We can see here, look, that there is a distal myotendinous rupture of the plantaris muscle. The hematoma is up there. We can see it here. Look, that this part is normal. But here we can see the plantaris tendon, but the big hematoma up there. And also we can have, look at this one, an isolated rupture of the plantaris tendon between the gastrocnemius and the soleus here. So, as idea, we need to know that the plantaris has this image, but it's more proximal and lateral, and the medial gastrocnemius is much more distal and medial. But the image is very similar in that case. And finally, a most important complication, deep vein thrombosis. About 10% of calf muscles goes with a deep vein thrombosis, tenderness, increased temperature, volume increase, all inflammatory signs. This is important to scan the whole area to find that there is an injury. This is a type 3 injury, but when we move proximal, we will find this gastrocnemius vein. When we push with the probe, we can see that this is deep vein thrombosis. This is a different case, it's very similar, it's also type 3. We move proximal, and we see, again, a deep vein thrombosis in the gastrocnemius vein. So we need to scan the whole area, but the signs of a deep vein thrombosis are very clear, because there is a big tenderness, there is a lot of pain, increased temperature, and an increase in volume of the muscle. And to take home just one conclusion about imaging. If you have a clinical suspicion of acute calf injury, first of all, we need to make an ultrasound scan after 48 hours. If it's positive, so if we see that there is a rupture, that means that it's a medial gastrocnemius or a plantaris injury. But if it's negative, if we do not see any injury, it means that it's a soleus injury, or probably it's a soleus injury if we have the suspicion, so we need to make an MRI. So this is the conclusion in terms of imaging test and calf muscle injuries. And remember that we have been speaking a lot of imaging tests and how to assess the calf here, but imaging and clinical diagnosis, it's just one of these amount of tips that we need to take into account when we plan a return to play process in a professional player, even in an amateur player, even in a normal patient. So we need to take into account all these things to be completely sure of about what we are doing in every moment. And I think that's all for my part in this speech. Hope you find it useful, and now we can make some questions and answers.
Thanks, Carlos. Thank you for my private tutorial. Just had 260 people join me. So that's very interesting. I'm just going to run through these questions. Some of the questions have been asked and some of the questions I've thought about. Just going back to the very practical use of imaging, you mentioned that for everyone you would do an ultrasound first and then an MRI if the ultrasound was negative. Would that be for everyone?
Yeah. For me, it could be applied to everyone.
Fine.
I think that if we work in a professional team, or we assess a professional team, we all know that they want an MRI now. This is the problem. But if we speak, other thing is that what they need or what they want. But if we just look at the imaging test, I think that everyone can be completely assessed the way I said. It's not necessary to perform an MRI immediately after an acute sharp pain in the calf. So I think that we can wait 48 hours, perform an ultrasound, and if it's negative, then we can make the MRI.
I completely agree. So the argument that we should be doing MRIs for elite athletes only, you don't espouse that argument at all, or you don't support that argument?
Not in calf injuries. I know, and I work with a lot of clubs, and they go running to make an MRI for the less than 24 hours after the sharp pain. But we can take this into the they have to do in political conditions with the player, but if we speak just about medical terms, I think that we can do exactly what I said, and it's very, very normal, and we will find diagnosis for everyone.
Interestingly, do you ever find conditions or calf injuries where you have both the gastrocnemius and the soleus affected?
Yeah. Sometimes there is a combination, the posterior aponeurosis of the soleus and the medial aponeurosis of the medial gastrocnemius.
How common is that? Because I'm thinking if I'm going to do an ultrasound and it'll show a medial head of gastrocnemius injury, do I need to do an MRI to show possible soleus injury?
Because the present in that case, it's because there is a quite important affection of the aponeurosis of the gastrocnemius, so there is quite a big hematoma, and the hematoma makes easier to see the posterior aponeurosis injury of the soleus. So we see the combination just with ultrasound. What I never found is, for example, type 2A or 2B injury in the gastrocnemius and the central tendon injury in the soleus. This I've never saw that.
Great. So we had a question about, whether you can assess these injuries without imaging, and whether you've correlated the clinical findings, because obviously you've seen a lot of these injuries, with the ultrasound and/or MRI findings. Have you ever done that specifically?
Yeah. I think that the most important thing is to know the injury mechanism. as we saw in the videos, the injury mechanism is very, very different in a gastrocnemius tear and a SOLEUS tear. So this is very important, because if the patient or the player comes to you and say, Lorenzo, I felt acute sharp pain and I need to stop immediately of my practicing, the suspicion will be of a medial gastrocnemius.
Sure.
But sometimes they come to you and they say, I felt just like a stiffness that it's overloading during the time. Yeah, I don't know exactly if there was a sharp pain, but I could end my practice, but with discomfort, you need to suspicious of SOLEUS. So,
I agree. I think SOLEUS can be very insidious onset, and you can get increasing pain with increasing activity. My concern is not picking those up, and it can be quite difficult, particularly when you're dealing with rugby players, for example, who get knocks all the time. They have calf pain all the time, really. Not all the time, but they do get a lot of knocks, so it can be very challenging differentiating the two. So we had lots and lots of questions about whether you can correlate, whether you can do the MRI classification of medial-headed gastrocnemius tears. So, i.e., can you just do an MRI to classify medial-headed gastrocnemius tears?
As I said, I never use MRI for the medial gastrocnemius. So I've been thinking if it could be useful to found the classification for the medial gastrocnemius injuries, but thinking about this, I realized that I never perform an MRI for the medial gastrocnemius. I perform MRI for every muscle group except for the medial gastrocnemius. So I try to correlate this classification in ultrasound with, for example, the British Athletics classification.
Yes.
And we try to do that, and it can be correlated, but it does not show the whole picture. So, for example, we have 5 different types in the ultrasound classification, and when I spoke with Professor Arnold and with Michael Giacomis about this classification, and in the British Athletics they found just 3 types of injuries according to that findings. The important thing is that they found a complete correlation with type 1. They found a complete correlation with type 2A, but type 2B, type 3, and type 4, which are the ones of the worst prognosis, they just find one type that shows it, the whole of them.
Sure.
It can be correlated, but for me, it gives
dynamic assessment as well. Yeah, there's not that dynamic assessment as well that you need, obviously, to look at that. So lots of questions about hematoma. When do you drain it? Do you drain it straight away? What do you do? Do you compress it? Do you get them active straight away? What happens if they recur? Well, what do you do there?
I drain always.
But you drain, and then what do you do?
And then if I reach a complete fuse with both aponeurosis, then I make a compression for 24, 48 hours, and then I re-scan it again.
And if there's a hematoma again?
And if there is a hematoma again, I drain it again.
Right.
So
okay.
I try to drain sometimes 6-7 times intramuscular hematoma, and you can see during these times that the hematoma is getting smaller and smaller and smaller. And as smaller is the hematoma, smaller will be the scar tissue, and better will be the synchronous movement. That's the only goal I want to reach with draining the hematoma.
So you think there's an acceleration of recovery if you keep draining it rather than leave it? Because sometimes I see cases that have had a calf tear 3 months ago, and you can see the scar tissue forming and significant scar tissue. It does heal, but it can take a long time. So your idea is to accelerate that process if possible.
It accelerates that process, but it also avoids future problems.
Sure.
in terms of muscle function due to this synchronous movement. So
right.
and it's not only about recovering fast. It's something to do in terms of avoiding future problems.
Okay. We also had questions about immobilization. So you mentioned when there's asynchrony, 2B and 4 and type 4, you immobilize them. Can you take us through what you do specifically? So from a practical perspective, what do you do exactly? What sort of cast do you put them in? Do you put them in a walking boot or a plaster? Are they in plantar flexion? How long are they in that cast for? Can you take us through the practical elements?
I put a walker boot and in neutral position. Neutral position, and I only immobilize, not in type 2B or type 4. I use it in that cases because are the cases that is where the aponeurosis is mostly affected. So I put an immobilization when there is a complete disconnection between aponeurosis of the gastrocnemius and the SOLEUS. So I need to drain the hematoma. Normally it's in type 2B and 4. I drain the hematoma, and if I try to approximate the aponeurosis, then I put a cast, I put a walker during 10 days to 15 days, and then I reascend in plantar flexion and dorsal flexion dynamic assessment, and I see if there is a little bit of connection. Yes. Depending on this connection, and if the movement is recovered, I remove the cast or the walker, or I leave it for 1 week more.
Sure. Okay. And then after that, what happens then? What is the process there of rehab? What do you do?
Starting physiotherapy treatment, and if it was, for example, type 1 or type 2A injury.
Yes. Okay. Fine. And there was some questions on, do you use ultrasound? I think I know the answer to this. Do you use ultrasound to assess the injury? So do you do repeat ultrasounds for all the injuries?
Absolutely.
Do you do them for type 1?
The problem with type 1 is normally you see it one day and it never comes back.
Never comes back. Right, yeah.
It's difficult to follow it.
And what are you looking for specifically on the ultrasound? Obviously synchrony, reduced hematoma. Is there anything else that you're looking for other than those two factors? In
the evolution?
Yes.
I look at the scar tissue, how it is going. Yes. If it's very hard, if it's very because scar tissue and fibrotic scar tissue could lead to a re-injury risk due to tension surrounding this scar tissue. So I always try to look how this scar tissue is in evolution. So just for this, not for and in case that I need to drain again, or in case that I want to assess if the synchronous movement.
I presume you use that as part with the clinical findings as well.
Yeah, so absolutely. Absolutely.
All that together.
I don't decide never the return to play time in a calf muscle with the ultrasound findings. This is just a help for me to see there could be a high re-injury risk, but the main findings that I use to program the return to play are the clinical findings.
Yes. Okay. Fine. What about surgery? Have you ever referred a player or a patient for surgery for a calf tear?
Not for calf tear.
Right.
Not for calf tear.
What about if it extends into the proximal Achilles? We'll talk about the FGA in a second, but have you ever referred on for surgery or opinion about surgery if you think there's an extensive proximal Achilles tendon tear?
If I can see a gap in the proximal Achilles tendon, I refer to surgery for an opinion.
Yes.
If I see a normal Achilles tendon tear, I always or almost always refer to surgery. Surgery. But in the proximal Achilles tendon, we need to understand that most of the cases we have the soleus below that makes a correct envelope of this proximal Achilles tendon. So this is not, there is not a loss of function strictly. So normally we do not need for surgery in that case also.
Okay. So you still refer on, but you would for an opinion to see whether they would think about an operation. But in your experience, most of them don't need surgical procedures. Just want to talk about the FGA for a minute, because that's I think that's an area that's missed a lot. So you get just this isolated rupture of the FGA. So my questions are, how long is the FGA generally? Like if you said, because you've seen, probably thousands of FGAs, is it variable or?
It's extremely variable as everything in the calf. So we try to measure in ultrasound, we try to measure in the cadaveric specimen, and there is very, very huge anatomical variability on the length of the Gastrocnemius aponeurosis. In my opinion, as lengther is this Gastrocnemius aponeurosis, it's more predisposal to a rupture.
Yes. Okay. And what happens if you? I mean, this is one that I think is missed because we're not looking for it, and it's only a small area. And it's very easy on ultrasound just to scan the medial head of gastrocnemius and then come down and scan the Achilles and go, well, everything looks fine. But in fact, you've got an injury at the FGA, which is potentially a serious injury because it can be part of the tendon. What do you do in those cases where you think it's FGA? How do you manage that specific case? Because it doesn't have asynchrony, and it often doesn't have a hematoma. So you're not, this is an isolated injury. What do you do?
I manage it as an Achilles tear,
right?
But without immobilization.
Okay. So what is that practically?
We start working very early, so 48, 72 hours with physiotherapy treatment, not in an open kinetic chain with the physiotherapist, and then we progress, but very much more progressively than if there was a muscle injury. Just taking into account as it was a rehabilitation of a tendon.
Right. And do you keep them in somewhat plantar flexion? Like, do you put a heel raise in them, or how do you manage those specifically? Like, you put them in a heel raise to walk into, or what do you do?
No. We try not to vary anything about his gait.
Right.
Because there is not an Achilles tendon tear, so it's just a small affection of a proximal connective tissue that is the same as a tendon, but it's not the Achilles tendon. So
yes.
We put a cast. We don't take to walking in uphill. So they walk normal as soon as they can. And the only thing is that in the return to play and in the return to sport time, we're very, very much more conservative than with injuries.
And how long do you put them in a cast for, the FGA specifically?
In a cast?
Yeah, in a cast. You said a cast.
I never put an immobilization in the FGA. So
you don't immobilize the FGA at all. It's just very slow, progressive.
Exactly. If there is a lot of pain during the first days, the same as the other calf injuries, I put them in crutches, but not with immobilization, because I want the passive movement of this injury.
Sure. Okay. I want to talk about a bit about other complications, so DVT specifically, because this is the one that I'm concerned about. What do you do? So it's interesting you're saying you ultrasound and you find the DVTs. I know that many of my colleagues in the UK would be uncomfortable with scanning for DVTs. Do you scan yourself or do you refer on? Because I know that they can use color Doppler to try and find the clots. How do you manage that? So what do you do if you're looking for a DVT?
I myself in the ultrasound, it's quite easy if you're looking for it, and the clinical signs are very, very, very clear normally. I scan it myself, and if I find a DVT, what I make is refer the patient to a vascular surgeon to make the complete scan, and then to put a treatment on that.
Yeah. Are you confident that you can pick up all the DVTs on ultrasound? Because I'm not. I'm just telling you what my experience is. I look for them, and I have found them, but I'm not comfortable making that clearance of someone if I'm thinking about a DVT. Are you confident in that?
If we speak about the gastrocnemius and the soleal veins,
yes,
I am confident of that.
Right.
If
okay.
a DVT in the deep flexor compartment or in the foot, for example, I am not confident, same as you. But in the gastroc and in the soleus, I'm quite confident of finding DVT are quite novel. The DVT in that areas are quite novel, and they show quite good. Not in the deep flexor compartment.
And how many, just out of interest, because you've seen lots and lots of these, how many times have you picked up a DVT in someone who was thought to have a muscle tear, and you know, scanning and you find a DVT? They might have muscle tear as well, but they have a DVT. So what average percentage, what do you think?
I have to say on that DVT, the series and the studies said from 7 to 10%, but I find a lot of them in my clinical practice. So scanning calf just for in a specific calf pain for 3 weeks evolution in a specific, nothing special, and you find a DVT. So I think it's very, very much more common than people may think.
Yes.
I can put a percentage exactly, but always think about it, especially in a specific calf pain. You put it perfectly in your slide that there are a lot of causes of calf pain, and we need to think about DVT also, because it's
definitely need to think about DVTs. Yeah, absolutely. And then the question about scar tissue, and I often see patients with recurrent calf pain from they get recurrent tears, but actually when you scan them, you see actually quite a lot of scar tissue. So they've just had probable hematomas. How do you manage those patients? What do you do specifically for scar tissue?
I try not to reach there. This is the main and the most important thing. That's why I do all what I said, just not to reach that point.
So you drain them, and absolutely.
It's, when you have a patient with that big scar tissue between the gastroc and the soleus, then that you find that there are very mild re-ruptures continuing in the scar tissue itself and surrounding it due to excessive tension, I think it's very, very difficult to manage that patient. So depending on do you have any magical tips or anything that you do that? No, absolutely. Just working, just try to stretch a lot that area.
But there are some colleagues in the UK that inject things like hyaluronic acid. I don't do that, but they look at trying to strip away the scar tissue. I'm not exactly sure what they're doing, but they say they get good results.
We published a paper about treating gastric tears with hematoma with PRP, and the results were not significant at all.
Sure.
So, hyaluronic acid, PRP, and everything you can put there, it's not significant. There is no significance. There is no evidence, and I don't use anything of that. If the scar tissue is very big, sometimes you can see that there is very big scar tissue between. Cases, I refer it for a surgery opinion and remove all the scar tissue.
Remove the scar tissue.
In the endoscopic image I share in the slide. So if there is problems like this and the scar and the fibrotic scar tissue is very, very big, I try to make a surgery opinion and remove it.
Okay, and I want to ask one more question about the SOLEUS. soleus injury, because I think this is really important. You know, all of us that work in elite sport will see soleus tears. They tend to be more common, I think, in the elite athlete compared to the weekend warrior. You had a very interesting slide there where you said that actually what we should do with soleus tears is not work them, in fact, leave them alone. Can you expand on that a little bit? What that means exactly? Because it goes a little bit against what I've been taught about muscle tears, about having to strengthen and you know, similar to hamstring or quadriceps. Just describe what you mean by that.
Yeah. So it's all my opinion. I speak with them, and this is how I treat the soleus injuries. And for example, we start working with physiotherapy and moving and trying to make a lot of exercise with all muscle tears. But for me, except in the soleus, we need to leave this injury to rest in peace for a week or 10 days, just passive moving, nothing stressing for the soleus. Obviously not jogging. This is the worst action. Not walking in the beach or sun training. Nothing like this. Just rest and passive movement for 10-15 days, and then we can start with a little bit of height, low, and normal, because it works the most with jogging and small actions. So it's better to rest more time and to start higher than start jogging at day 3 when the patient is pain-free.
So it really is a little bit. It goes against what we tend to do for other muscle tears. It's quite interesting. Yeah. And I want to ask one more question. I know we're out of time. Thank you for the private tutorial, by the way. It was really good. So the last question is, when are you going to publish your treatment protocols for the classification? It is interesting. This is a really good question. Because I'll explain. Because if we're saying every slide that the treatment should be individualized, I don't believe in papers published about treatment protocols, because every protocol should be individualized. So I need to know the exact injury. I need to know where exactly it is. I need to know exactly which structure it affects, what is this player position in the field, which sport he plays, and then I can publish a paper just with one case. So Good point.
So that's it. That's my opinion.
It's very difficult. I agree. Great. That's it for me.
Well, thank you, Carlos, and thank you, Lorenzo, and thank you to our delegates who have stayed up late. In some cases, I can see people in Australia, New Zealand, and Qatar, so thank you for our international delegates. This lecture will be online. Our next seminar is next month, and that will be on injury nutrition. So what to do for those athletes who do become injured for a prolonged period of time. How can we support them nutritionally, which is often an studied and a very neglected area. So that will be with Dr. Richard Allison at Arsenal Football Club. So thank you, everybody. Thank you, Carlos. Thank you, Lorenzo. Have a great evening, everybody.